Let me call the hearing to order and thank the senators who are here, and to mention that the issue that we are discussing today is a very sobering issue, and is an issue I think does not get the kind of attention that it deserves. And let me thank Ranking Member Collins for her interest in the topic. Let me thank Dr. Kathleen Harris, Dr. William Cook, and Police Chief Robert McKenzie for joining us for this hearing today. They're going to be with us virtually. In the United States Congress, we have our differences of opinion, to say the least. But I think every member works hard on the issues of importance to his or her state or congressional district. But I think sometimes we may, in the midst of our work, lose sight of the big picture, the really big picture of what I think all of us want to accomplish. And very simply stated, what I want, and I believe members of the committee want, and certainly the American people want, is to create a nation in which the people in the United States can live long, healthy, happy, and productive lives. At the end of the day, that's what we are fighting for. Unfortunately, the issue we are discussing today, as I mentioned, does not get nearly enough attention, but it is surely an ongoing tragedy, something that we need to focus a lot more work on. And that is that here in the wealthiest nation in the history of the world, where we spend far more per capita on healthcare than people in other countries, the truth is that our life expectancy, how long our people live, trails behind many other industrialized countries. And tragically, and the question of today, what we're discussing, is life expectancy in the United States right now for many, many people is in decline. And when we discuss the issue of life expectancy, the real outrage, it seems to me, and this is above and beyond the horrors of the COVID pandemic, is that not all of our society is seeing a decline in life expectancy. What we have seen over the last number of years, again, pre-COVID, is that this declining life expectancy is impacting lower income and working people in a very significant way, people with less education and people who live in rural areas. In terms of life expectancy, as it happens, the very wealthy are doing just fine. The crisis impacts particular people, working people, lower income people, people living in rural communities. One of the most alarming facts, I think, that we have to address as a nation is that today, and I want everybody to hear this, an upper income male lives 15 years longer than the poorest male. And the gap between women is 10 years. According to a report by the Health Inequality Project from 2001 to 2014, the wealthiest Americans gained approximately 3 years in life expectancy, while the poorest Americans experienced no gains. A 3-year difference in life expectancy may seem trivial. What's 3 years? But as the report's authors note, this gain in lifespan is the equivalent of curing cancer for only the wealthy. Imagine that. Wealthy get cured, everybody else does not. Let me give you another example. If you are upper income, if you have stable housing, if you have access to decent medical care, you're doing fine today. In Fairfax County, Virginia, for example, the median household income is $124,000, and the poverty rate is just 6%. A child born in Fairfax County, Virginia today could expect to live to 85 years of age. That is pretty good. It's pretty good in terms of international standards. It is good. But in Scott County, Indiana, where Dr. Cook has his medical practice, the median household income is $48,000, and almost 14% of the community lives in poverty. A child born there today could expect to live only 71 years. Imagine that. 14-year discrepancy between Fairfax County, Virginia, Scott County, Indiana. In other words, what we are discussing today, and this is such an important point, is poverty is not that, you have a big house, I have a small house, you're driving a fancy car, I have a broken old car. That's not what we're talking about. What we are talking about is that if you are wealthy in America, you will live many, many more years than if you are poor. So it's not a question of luxuries. It's a question literally of poverty and stress being a death sentence. And all of this is preventable. And I think and hope that all of us can agree that this reality of today is a moral and economic failing. Over the past 10 years, the disparities have grown exponentially, and this is above and beyond the onslaught of the COVID pandemic, which has done, all of the horrible things and the deaths that it has caused. As we will hear from Dr. Harris today, mortality is now flat or rising among most working-age populations. Socioeconomic disparities have widened substantially, especially by education levels. People who have obtained a bachelor's degree are doing much, much better than those who have not gotten that quality of education. And what makes this even more stark is that many of these premature deaths are preventable. This is not about needing more advancement in medical research. In fact, cancer death rates are declining for more than half of the most common cancers in the U.S. We are making significant progress in many areas. This is not about healthcare. We are seeing a nationwide crisis of what doctors call, quote, deaths of despair. Deaths of despair, end quote. What does that mean? It means that we're seeing an increase, and we'll discuss this today, of drug overdoses, opioid epidemic, alcoholism, and even suicides. A Stanford neuroscientist, Robert Sapolsky, who has been speaking and writing on this topic for decades, offers a simple answer as to why we are seeing this decline in life expectancy. Poverty and economic stress is what he says. The psychological impact of being poor. A life of poverty can mean a life of constant stress. And this is the point that I think people don't understand. Again, it's not having a fancy car. It's living every single day wondering how you're going to feed your kids, how you're going to pay the rent, how you're going to prevent yourself from being evicted. What toll does that have on all of us? It's extraordinary. The poor have little control over their work schedules, whether they have jobs, how much money they make. They fear suddenly losing the job, being unable to pay their electric bill. What happens if your electric bill goes out? What happens if you don't have a cell phone? They despair over their own future and how to give their children a better life. They are exhausted and socially isolated by second or third jobs, long commutes, and weekend shifts. They lack the means to take much-needed time off or pay for relaxing hobbies. And often their social support systems are decimated by incarceration, addiction, and depression. And I can go on, but I think I've kind of laid the table for what I hope we will be discussing today. I know Senator Collins has long been interested in these kinds of issues. We appreciate your help. Senator Collins.
Thank you very much, Mr. Chairman. This is an extraordinarily important hearing that you're holding today, and I appreciate your convening it. The pandemic and its consequences have exacerbated many of the problems that were already fueling declines in life expectancy. Just this morning, the Wall Street Journal reported that U.S. life expectancy fell by 1.5 years in 2020. That's the biggest decline in generations, and the largest drop was among Hispanic men. One of the clearest consequences of the pandemic is the escalating incidence of behavioral health problems and substance abuse disorders. Overdose deaths have soared by 30% during the pandemic. Last year, 504 Mainers died, from overdoses, a tragic record that exceeded the deaths caused by COVID-19 in 2020. Let me say that again. More Mainers died from drug overdoses last year than died from the tragic pandemic. Regrettably, 2021 may be even worse, as Maine has averaged nearly 50 overdose deaths a month so far this year. Like Americans of all ages, young adults had a tough time coping with the pandemic, the lockdowns, and other consequences, and they reported much higher levels of anxiety. In a CDC survey conducted last summer among young people aged 18 to 24, nearly a quarter reported that they had started or increased their abuse of substances to cope with pandemic-related stress or emotions. The survey also revealed that 25% seriously considered suicide. Many who have struggled with the chronic illness of addiction long before the pandemic found it more difficult to access the treatment they needed, to participate in counseling and peer-to-peer support during the pandemic. As young adults start to become parents themselves, the stakes have become infinitely higher. In Maine, about 8% of babies born in 2018 had some degree of neonatal abstinence syndrome. This summer alone, a 3-year-old from Old Town died, and an 11-month-old from Corinna suffered a near-fatal fentanyl overdose. In 2017, the Portland Press-Herald ran a 10-part series titled Lost, Heroin's Critical Killer Grip on Maine's People. And one of the installations in this series focused on women and the challenges that they face. The article said that when it comes to opioids, women are at a deadly disadvantage. They are dying of overdoses at increasing rates compared with men. They get addicted faster and feel withdrawal more acutely. They are often dealing with sexual trauma as well as their addiction. They tend to avoid seeking treatment if they are mothers because they fear their children will be taken away from them. And when they do ask for help, there are fewer resources available for them. One of the themes that we will hear today is the importance of engaging local communities, the structure and connection that can be found in employment, schooling, church, and community groups not only helps with identity and giving life a sense of purpose, but also they can be an essential source of peer support. I'm very pleased that with us today is Kennebunk Police Chief Robert McKenzie, and he will talk about his impressive efforts, including working with Rotary International. Another theme which is near and dear to the chairman's heart as well as mine is access to health care. For example, those working in highly physical and dangerous professions, such as the lobster or fishing industry, for them, the time and travel to take care of anything other than emergency healthcare needs can deter them from seeking regular care for conditions like high blood pressure and diabetes. Last year, I joined a bipartisan group of senators in introducing legislation to expand telemental health services in rural areas. The Home-Based Telemental Healthcare Act would establish a grant program for health providers to provide this telemedicine service for those in farming, forestry, and fishing industries. Another focus of the National Academies of Science report are cardiometabolic conditions. I'll never forget last year the owner of an ambulance service telling me that his calls were way down. And it wasn't due to the fact solely that there were fewer automobile accidents as people were not driving. It was that people who were experiencing symptoms of heart attacks were afraid to go to the hospital during COVID. And they should have. We also saw people putting off treatment and screenings that might have uncovered cancer at an earlier age. Here again, community interventions, such as those where people can participate virtually, like diabetes self-management training, can help change the trajectory of life expectancy. As we continue to grapple with the Delta variant and emerge from the pandemic, we should take stock in the areas where we've done well, like telehealth, as well as analyze those areas that have worsened, like substance abuse disorders. So this hearing is very well timed, and I look forward to hearing from our panel. Thank you, Mr. Chairman.
Well, thank you very much, Senator Collins. Senator Casey has to run, so I'm going to ask him if he would like to speak for a few minutes.
Mr. Chairman, thanks very much. I want to thank you and the ranking member for convening this hearing, and I'll be brief. I start with an apology that I won't be able to stay for the entirety of the hearing. I'll make sure that I and my staff review the testimony, the written testimony of Dr. Harris, Dr. Cook, and Chief McKenzie, and then submit questions for the record. But I want to thank you, Mr. Chairman, and the ranking member for having this hearing. The documented decline in life expectancy for working-age adults in our nation and the socioeconomic disparities that are part of that trend are alarming, disturbing, and I think call all of us to do something. Mr. Chairman, when you were talking about in your opening remarks the impact of stress and poverty on people having not just an adverse health impact, but literally being, for some people, many people, a death sentence. That caught all of our attention. And the deaths of despair that you made reference to should call all of us to action. I know in Pennsylvania we have still a huge challenge with substance use disorder. I have to say the Medicaid expansion in our state helped a lot, but the pandemic wiped out a lot of those gains. More than 16%, the number of overdose deaths in our state increased, I should say, by 16% from 19 to 20, and that doesn't, of course, cover the whole impact of the pandemic. So I'm grateful for this indulgence, but and grateful for this hearing. Thank you.
Thank you very much, Senator Casey. Now we'll get to our panelists who are with us virtually from around the country. And let me begin by introducing Dr. Kathleen Harris, who is a professor of sociology, adjunct professor of public policy, and faculty fellow at the Carolina Population Center at the University of North Carolina. Dr. Harris's research focuses on social inequality and health, and she is the chair of the Committee on Population at the National Academics of Sciences, Engineering, and Medicine. Dr. Harris, thank you very much for being with us today.
Good morning, Chairman Sanders, Ranking Member Collins, and members of the subcommittee. Thank you for the opportunity to testify today. My name is Kathleen Mullen Harris. I'm the James Harr Distinguished Professor of Sociology at the University of North Carolina, Chapel Hill, and I'm speaking to you today in my capacity as chair of the National Academies Committee that produced the study High and Rising Mortality Rates Among Working Age Adults. Well, as you just heard, our study was motivated by a huge problem. Between 2014 and 2017, life expectancy in the United States fell for 3 years in a row, the longest sustained decline in a century. To make matters worse, this was not happening in our high-income peer countries. So we wanted to understand why more Americans were dying in the prime of their lives, ages 25 to 64. Their most productive years and their parenting years. So we first set out to identify what causes of death were increasing and for whom. We examined trends from 1990 to 2017 and identified three main drivers of rising mortality: deaths due to drug poisoning and alcohol-induced causes, suicide, and cardiometabolic diseases like hypertension, diabetes, stroke, and heart disease. Rising death rates first occurred among younger white women and men, those aged 25 to 44, living outside of large cities, but then spread to most racial and ethnic groups and geographic areas of the country. Although rising death rates began among whites, Blacks consistently experienced much higher mortality. Those with less education and income always experienced higher death rates, and this disadvantage was widening among whites. Geographic disparities also widened between large urban areas and less populated rural areas where death rates were increasing more rapidly, especially in Appalachia, New England, the industrial Midwest, and parts of the Southwest and Mountain West. So what was happening? We then searched for explanations through an extensive review of the existing research literature. Drug and alcohol-related deaths were the most important contributor. Explanations involve supply-side factors like weak governmental oversight and actions by the pharmaceutical industry, pain control advocacy groups, and physician prescribing. Demand-side factors included increasing prevalence of physical pain, declining psychological health, and long-term trends of economic adversity that affected adults with less than a college education and geographic areas where manufacturing and mining jobs had disappeared. Suicide rates increased primarily among whites, especially white men, and in less populated rural areas. Economic factors are important. Economic downturns, low wages, increasing foreclosure rates, and a weak safety net increased suicide rates. Cardiometabolic diseases also played a significant but a complex role. Up until 2010, science was saving us. Medical interventions and public health campaigns to reduce smoking drastically brought down cardiovascular death rates. But these declines hid the mounting tsunami of the obesity epidemic, which was fueling alarming increases in hypertension, diabetes, stroke, and heart disease. By 2010, the lagged effects of obesity overwhelmed what medicine could do to save lives. So as you can see, there is no one cause that explains the increase in death rates, but we noted three common factors underlying all the trends: economic adversity, socioeconomic inequality, and vulnerability. Every one of these trends and the themes underlying them are being magnified by the COVID-19 pandemic. But this is a crisis in America that existed before COVID, and it will continue after COVID. Our life expectancy is declining relative to our peers, despite our wealth. Solutions need to be multifaceted. The committee made several recommendations. We need policies that can be implemented for those agencies and stakeholders closest to the addiction crisis, to improve regulation and oversight and modify practices to support the prevention and the treatment of substance use disorders. Economic policies are needed to address the economic and social strains that made communities vulnerable to opioids and other drugs. Obesity prevention programs need to start early in life before obesity and focus on the most vulnerable, often the low-income populations. And we need to balance the rights of the food industry and public health imperatives to reduce food and beverages that contribute to obesity. Death rates are lower in states that have expanded Medicaid under the Affordable Care Act. The 12 states that have not yet expanded access to Medicaid should do so as soon as possible. And all studies of mortality report on the stark disadvantage in life expectancy among racial and ethnic minorities in the United States. Reducing this racial gap will significantly help to improve our global standing in life expectancy and catch up to our other rich nations. Thank you for the invitation to testify, and I welcome any questions you have.
Dr. Harris, thank you very, very much. I believe that Senator Braun is going to introduce Dr. Cook. Senator?
Thank you, Mr. Chair and Ranking Member Collins. My pleasure to introduce Dr. William Cook, a fellow Hoosier, graduated with honors from the IU School of Medicine in 2001, completed his family medicine residency at Ball Memorial Hospital in Muncie, Indiana. Dr. Cook is a fellow of the American Academy of Family Medicine and the American Society of Addiction Medicine, specializing in addiction and HIV medicine. He's received national recognition for quality and compassionate care including being named Family Physician of the Year by the American Academy of Family Physicians. Dr. Cook lives in his hometown of New Albany with his wife, Melissa, and their 6 kids. He also serves as the executive director of a nonprofit, Refresh, the hospitalist medical director at the Critical Access Hospital in Scott County, and co-director of the Rural Center of HIV and STD Prevention. In 2015, Austin, Indiana became the epicenter of the national opioid crisis and the worst drug-fueled HIV outbreak in U.S. history. At the time, Dr. Cook was the only physician in this rural southern Indiana town. In response, he and his team went the extra mile to improve their own capacity to care for people living with HIV, even going door to door in his community to provide care for the people newly diagnosed. Today, almost 80% of Dr. Cook's patients living with HIV have undetectable viral loads. Dr. Cook continues to provide full spectrum primary care to those in his community, including the people with substance abuse disorders and mental health challenges. Look forward to hearing your testimony today.
Dr.
Remember
Cook.
just a few seconds to thank Senator Braun and the other panelists, Sheriff McKenzie and Dr. Harris, for presenting today. So good morning, Chairman Sanders, Ranking Member Collins, and the other members of the subcommittee. I've spent the last 2 decades working to increase health equity in underserved areas of southern Indiana. That's where I grew up, surrounded by poverty, toxic stress, and substance use. And those factors actually contributed to my grandpa's death in his 50s, my aunt's overdose death at the age of 39. And although my parents escaped that fate, providing my brother and me greater opportunity, our family remains an example of how early deaths profoundly affect life expectancy. During medical school, I was impressed by our nation's investment in research and technology. There's no place on earth better at keeping sick people alive. After graduating as a family physician, I felt prepared to care for the entire community at my rural health clinic, regardless of the age or condition. At our critical access hospital, I delivered babies, worked in the emergency department, and treated critically ill patients. Even so, nothing could have prepared me for the suffering I found in the nation's heartland. Young people with late-stage diabetic complications, women dying of cervical cancer, and a man with a tumor on his tongue so large he couldn't even close his mouth. These encounters made me realize that we've focused so heavily on treating sick people that we forgot to promote healthy people. As the Surgeon General's report on community health and economic prosperity indicates, our nation is at a health disadvantage due to inequitable access to vital community conditions that shape health and well-being, such as clean air and water, nutritious food, safe housing, reliable transportation, a livable wage, and a sense of belonging and civic power. There are far too many people, like my patients, who lack these vital conditions. Children don't choose where they're born or where they're raised. And if they were born into these low opportunity neighborhoods, their life chances are diminished all the same. Life was more comfortable before I recognized these inequities. My discomfort caused me to cling to beliefs that I had been taught about people who were different than me. But close encounters with real people convinced me that health and prosperity are not solely dependent on effort or choice, but are often limited by access to resources and opportunity. After all, people can only make choices from the options available to them. The greater the inequity, the greater the burden of disease, disability, and early death. We must move beyond the passive, disease-oriented model of do no harm to a proactive, person-centered model of protect from harm. And primary care physicians are uniquely positioned to do just that. Research confirms access to primary care improves health outcomes and life expectancy. Now, you've heard a lot of bad news from the report. Let me just share some hopeful progress we've made in Indiana. As Senator Braun mentioned, my community experienced the worst drug-fueled HIV outbreak in U.S. history in 2015, but things look a lot different today. Despite having the highest percentage of people who inject drugs living with HIV in the state, we've defied conventional wisdom by being able to boast the best viral suppression rate in the state. We went from nearly 200 new cases a year to only 1 last year. And although Indiana leads the country in hepatitis C cases, we've cut our community cases by over 75%. We've also seen an explosion of people with substance use disorder entering into treatment and recovery, along with fewer diabetic complications, better pain management without the use of opioids, improved prenatal care, fewer hospitalizations, and the list could go on. We did this with very limited resources, and I believe we've reduced the impact of social determinants on our community by getting outside the four walls of my clinic and getting into where people live and experience harms. A few examples include school, jail, and mobile clinics, working with the sheriff and the recovery community to respond to overdoses and people in crisis by providing them direct access to treatment. Project ECHO enables my team to provide interdisciplinary access to endocrinology, rheumatology, infectious disease, addiction medicine, and women's health. Telehealth allows patients greater access to us and to their support networks, and interdisciplinary teams with diverse lived experiences help my patients feel safe accessing care and overcoming barriers. Integrating healthcare with Centerstone, a nonprofit behavioral health system, allows for decreased stigma and barriers to mental health. Community, recovery, and faith-based partners help meet basic human needs for food, safety, and belonging. Now, our fee-for-service system doesn't reimburse for these interventions, which highlights the need to move towards a payment model designed to address health inequities. Healthcare disasters don't just happen. They develop right before our eyes, unseen or ignored before it's too late. Then the people who are already suffering are the ones who are harmed the most. We must recognize the cumulative effect of every person's health on our nation's health. By taking this crisis of health inequity and declining life expectancy on now, we can reestablish the United States as the healthiest place in the world to live. Thank you for the opportunity to discuss this important topic with the committee, and I look forward to your questions.
Well, Dr. Cook, thank you for testifying and congratulations on your work. Senator Collins is going to introduce Police Chief McKenzie.
Thank you very much, Mr. Chairman. I am delighted to introduce Kennebunk Police Chief Robert McKenzie. He is a 33-year veteran of law enforcement. The chief recently received the Outstanding Contribution to Law Enforcement Award from the Maine Chiefs of Police Association for his incredible work in the field of substance abuse disorder in 2020. This was certainly a well-deserved honor and recognition from his peers. Chief McKenzie is a graduate of the FBI National Academy in Quantico, Virginia, and he holds a Bachelor of Science degree in Criminal Justice from Hudson University. He is a true leader in this area, and I'm delighted he's joining us today. Thank you.
Chief.
Thank you, Chairman Sanders and Ranking Member Collins and members of the Health Committee. So I am Bob McKenzie, a police chief for 13 years in the town of Kennebunk, but I've been in law enforcement for over 33 years and actually in public safety since I was 14 years of age as a firefighter and then as an EMT from 16 years of age. I'm also a Rotarian, past president of the Kennebunk Rotary Club. I also chair the Rotary District 7780 Recovery Initiative. I also serve on the board of directors for Milestone Recovery in Portland, Maine, and the United Way of Southern Maine. So I've witnessed far too many times the tragedies due to the opioid epidemic and the disease of substance use disorder, otherwise known as SUD. Now, as devastating as these losses are, it became even more real for me when I realized my daughter was suffering from an opioid use disorder. Now, because of my work around SUD have specialized in the opioid epidemic, I knew my daughter was at great risk for death. I was fortunate to have the resources and know-how in order to help my daughter find her path to sobriety, and I'm proud to say she's more than 18 months in recovery now. I also know that there are many loved ones not as fortunate as mine, and 2020 certainly proved to be a devastating year, and not only because of COVID, but because of the loss of lives to SUD and the opioid epidemic. The most recent national statistics I've seen for 2020, as Senator Collins stated, was a 30% increase over 2019, but that equates to about 93,000 Americans that died. And what's important to remember is that these stats are somebody's loved ones. Now, on a positive note, resources for SUD have and will continue to adjust for the pandemic, and we are becoming very creative as to our approach. We've implemented a number of initiatives in our region over the past 5 years, and I will share 3 of them that I believe are most relevant for this discussion. The first thing I knew we needed to do is reduce stigma, because stigma is the #1 barrier for those that suffer from SUD to enter recovery. Stigma related to SUD is far too prevalent in our society, but once people are educated, they tend to open their minds and their hearts. I began educating our Kennebunk Rotarians on SUD and the opioid epidemic, and trained many of them how to use naloxone, which is the drug that reverses an opioid epidemic, overdose that is. I went on to train our Chamber of Commerce, our businesses, held several community forums, and even students at Kennebunk High School. I've trained at least 35 Rotary clubs throughout Maine and New Hampshire, all with the goal of raising awareness and reducing stigma. Now, another initiative that's currently underway in our community is called the Kennebunk Area Response to Substance Use Disorder. This is where we convene stakeholders of 3 towns to include our town managers, law enforcement, physicians, recovery centers, faith-based leaders, mental health providers, those in recovery, and more. We first identified the issues surrounding SUD, what resources we currently have, but even more important, we identified gaps so we can create a strategic plan to close those gaps. This type of initiative educates everyone as so we're all on the same page, we're more efficient, cost effective, and we're not working in silos any longer. The third initiative is the Kennebunk area includes a community-based fundraising group called Above Board that came forward with a desire to raise money to support our efforts on saving lives. A total of $110,000 was raised and was utilized to train community members to become recovery coaches. A recovery coach is a mentor to those with SUD and helps them find their path to recovery and stay in recovery. Now, in addition, these funds were used to train our law enforcement officers on how to help those with SUD. Now, there are times when law enforcement needs to use enforcement, but there are many more times when law enforcement officers can be an ally and help those in need. I'm proud to say that this model of law enforcement training became a mandatory training module for all of our officers in the state of Maine last year. These are only a few of the initiatives we have undertaken in our region. Our community is dedicated to helping those with SUD because we know recovery is possible. I've seen it through my own family and even more so at work, where those struggling with SUD were at great risk of death, but are now healthy, happy, and productive citizens who are doing great work to strengthen the recovery community. The key word here is community. So by working together at the local level where we know our communities the best and have the ability to utilize the resources of the state and federal governments, we will make a difference and save lives. I thank you for your time and attention to this matter and welcome any questions that you might have.
Chief, thank you very much. Let me begin the questioning with Dr. Harris. Dr. Harris, not only are we seeing a decline in life expectancy in many parts, many sectors of our society, but we have for many years lagged behind other wealthy industrialized countries. What impact would it have on life expectancy in America if all of our workers had decent wages, so there was at least a livable wage, decent housing, and if we did what every other major country on earth does and provide health care as a human right? Would that, in your judgment, impact life expectancy in the country?
Yes, it would. A lot of people look at the differences in life expectancy between the United States and our peer countries and, attribute it to the racial and ethnic disparity. But even if we eliminated that, we would still be behind. So the cause is much deeper and broader, and it's rooted in inequality, socioeconomic inequality, poor economic conditions, and the stress of living with those conditions. And so I think that opportunities for jobs, if everybody had a job, that would provide them with a sense of meaning and dignity and purpose in life. And it would allow them to take care of their families, help promote their children for upward mobility. And I think that would really cut to the heart of helping us catch up to other rich nations in life expectancy.
Thank you very much. Let me ask Dr. Cook a question. And congratulations, Doctor, for the work that you're doing, taking healthcare out of the clinic into the community. Talk a little bit about, if you might, the physiology of poverty. What happens to somebody who is struggling economically, who maybe has given up hope for himself, herself, the kids? How does that impact their outlook on life and their tendency to use drugs, alcohol, suicide, self-destructive behavior?
Yeah, oftentimes when I'm working with people, I realize that they have made a lot of effort in their life to get to where they wanted to be in life, but somewhere along the way, circumstances had appeared to be so overwhelming that they develop this sense of learned helplessness. No matter what they do, they can't get ahead. And one of the things that I've found is the most helpful when I'm working with people is trying to reestablish within them this sense of purpose and meaning. And when they find that and they're able to project that into the world, all of a sudden, some of those circumstances don't seem as overwhelming any longer. And when we look at substance use disorder, the recovery community is such a vital piece of that. But toxic stress is damaging to the body. It's damaging to the mind, the brain, the way it's developed with childhood, adverse childhood experiences. It disrupts the neural development, and it leads to these behaviors that then lead to poor health outcomes, unfortunately.
Thank you. Chief McKenzie, as a police chief, you and your department are on the front lines every day dealing with these things. In your personal judgment, what are the causes today that bring young people especially to a dependency on drugs or alcohol? What's going on?
Certainly. Well, I agree with regard to the issue around adverse childhood experiences. A lot of research has been, scientific research has been done on that. So children that grow up with adverse experiences in their home are much more likely to have issues, anywhere from suicide, health issues, but also substance use disorder. And so any child that grows up in that type of environment, they could be subject to substance use in their home, separation and divorce of their parents, mental illness, domestic violence, neglect, both emotional, physical, or sexual abuse. The more issues that they have, the more chances are that their life expectancy is going to be shorter. I know there was a Florida study of juvenile offenders where 50% of them had ACEs score of 4 or more. And to put that in perspective, those with ACEs scores of 4 or more were 12 times more likely to have attempted suicide, 7 times more likely to be an alcoholic, or 10 times more likely to have injected street drugs. And ACEs scores of 6 or higher, and almost 20-year shortening of lifespan. So I definitely feel that ACEs has a lot to do with it.
Okay. Well, thank you very much, Steve. Senator Collins.
Thank you, Mr. Chairman. Let me begin my questions by first thanking Chief McKenzie and Dr. Cook for so eloquently sharing with the committee your own family's struggles. It certainly puts a human face on the statistics, and it reminds each and every one of us, if we don't already know it, that no family is immune. And I think that's a really important lesson. So thank you for your willingness to share your own personal stories. Chief, I want to start with you. Prior to the start of the COVID pandemic, we started to see some glimmers of progress in the state of Maine. I remember in 2018 and in 2019, the number of deaths, while still unacceptably high, was going in the right direction. It was declining. Then Congress had passed a lot of legislation to help, including a bill that I co-authored related to opioid peer-to-peer support networks and safe disposal of unused medications. And Congress also significantly ramped up the funding that we provided. And yet, once the pandemic hit, we seem to lose all of the progress that we made. And indeed, as both you and I've mentioned, Maine experienced a record number of losses, 504 deaths last year, which was a 33% increase over the year before. What happened? What factors do you think caused us to lose the ground that we were gaining?
Certainly. So once COVID came, what we were told to do was isolate. Now, substance use disorder is a disease of isolation. Many people that use in solitude. They're by themselves when they use in many instances. In addition, many of the resources that had become available were really no longer available, especially the peer-to-peer support, the in-person meetings that were being held. Now we tried to struggle through that and come and be creative and maybe do some meetings via Zoom and other platforms. But one of the issues is that many people that utilize substances do not have the resources or the ability to go online. It's not just that easy for them. So COVID certainly just forced the issue of isolation more, and I believe that's why we've seen such an issue with the deaths increasing.
Thank you. Dr. Cook, in the chief's testimony, he referred to the stigma of getting assistance. I believe it was the chief that mentioned that. And I've seen that time and time again in talking with friends who are struggling or have children who are struggling. I've also seen a success story in this regard, and that is at the VA. The Veterans Administration has been using telemedicine to reach out to veterans in rural areas who are struggling with substance abuse disorders or other behavioral health challenges. And what they have found is their no-show rate has dropped dramatically, and that the veterans felt much more comfortable with telemedicine counseling and treatment sessions than they did being seen going into a counselor's office. Now, that's sad that there is that stigma, but I wanted you to comment. You alluded to the fact that we need to revise our reimbursement policies because we temporarily are reimbursing well. COVID is going on, but I fear that's going to come to the end. How important is telemedicine in reaching people, and how important is that reimbursement?
Thank you for that question. We told everybody to socially isolate, right? Socially distance from each other. And I think what we meant by that was physically distant from other people. We really needed to maintain our social connections with other people, and telemedicine is a wonderful tool to be able to do that. It doesn't replace in-person meetings, it doesn't replace face-to-face interactions with people, but it does allow us to stay connected to people that we would otherwise be physically distant from. If you look at the Ryan White program, there's a reason why the viral suppression rate of people living with HIV in the Ryan White program is better than in other clinics. And that's because they address those underlying critical vital community conditions, those social determinants of health, that social health inequity of transportation and such. By allowing those Ryan White funded clinics access to money that can provide transportation, that can provide social interactions and support groups. We just recently developed a statewide support group for people living with HIV, so they know they're not alone, and we can get through this together. So I think looking at unique ways to reimburse, better ways to stay connected with people, to support them having those access to vital community conditions would help support healthy people and not just continue to focus on the disease model.
Thank you.
Thank you, Senator Collins. Senator Murphy.
Thank you very much, Mr. Chairman. Thank you, and Senator Collins, for convening this really important hearing. Thank you to the three of you for the great work you do in this field. I appreciate the focus that we've already heard today on the social determinants of health. I think you've all covered it in one way or the other. Senator Sullivan of Alaska and I have introduced legislation that would set up a series of grants to communities to better integrate healthcare services and social services. Dr. Cook, I wanted to, because you've raised this in a couple different ways in testimony and answers to questions, wanted to ask you your advice on how to structure the kind of programming necessary to link together social services, whether it be nutritional services, housing services, job training services, and healthcare services. Is that better off housed on the social service side, better off housed on the healthcare side, better off done by third parties that are bringing everybody together in one communal table? Have you found any way that this works better?
I would say all of the above. The students from Yale just recently published a report on public health funding, and that's one of the things that they looked at is kind of thinking outside the box and not just funding health departments and nonprofit health centers, but actually funding the entire community through coalitions. And I think it takes the community all working together across the sectors to really address those underlying social determinants of health. There's a model called ROSC, Recovery-Oriented Systems of Care, and it looks at the unique factors within each unique community, because every community is different and looks different and has different needs. And it allows that community to figure out what's keeping people down, what's keeping people from being healthy and well and having purpose and meaning in their life, and allows the cross-sector coalition to develop strategies and definitions that the entire community can get behind, and then start developing programs across those different sectors to surround people with all the help that they need to enter into recovery whenever they're ready. Hope that answers your question.
It does. And I think that the importance you place on flexibility and recognizing that every community is different is important. Dr. Harris, I wanted to talk to you about the impact that gun violence has on life expectancy. The data I've seen is fairly remarkable. Nationally, the total life expectancy loss due to firearms was about 2.5 years. As you would imagine, that's a very different number for white Americans, about 2.2 years, versus black Americans, 4.1 years. And it strikes me that while that data is relative to the gun violence death itself, the leading cause of death today for African American young men 15 to 24, to the chief's point, the trauma of being exposed to gun violence, especially at an early age, also must have an impact on life expectancy, given that we know those early traumas lead you into riskier behaviors later in life. So just wanted to get a sense of how much research is being done on the impact of gun violence, both the rate of death itself, but also the trauma involved in living in violent neighborhoods, and how much that factors into this national conversation about life expectancy.
Yeah, thank you for that question. There sort of needs to be a two-part answer to this. In the report, we were focused on what was causing the rise in mortality. And there's significant evidence showing that states that have looser gun laws and more guns have higher rates of suicide and death, as you said, especially among young adults for whom that's one of the highest leading causes. However, the increase to access to firearms, we found did not really explain the rise in mortality because other means of suicide, for example, were contributing, more deaths, like suffocation, for example. However, it goes without saying that when there is greater access to firearms, the deaths that we were examining of mortality in this report are higher, as well as deaths due to violence. Now, so that's one part. The second part is the access to firearms is clearly an important contributor to violent death rates. And as you said, there's been a lot of sort of new research around not just the victim and the perpetrator and how these experiences affect them, but the exposure of family members, neighbors, communities in which crime and violence is higher. And the one thing that we have found is that, going back to the report, the importance of communities, which is something that everyone has been sort of talking about. We think that one of the reasons that we have an increase in cardiometabolic deaths, for example, is due to the neighborhoods in which people live. People who live in unsafe neighborhoods with high crime don't have access to open spaces to exercise and can't enjoy a lifestyle that will help them keep their weight down and avoid obesity. They don't live in neighborhoods where they can walk around the corner to the grocery store and get fresh foods and fruits. So it's a very important problem that research is only now beginning to address. Because for a while the surveys didn't really include questions about guns and guns in the household and being a victim or witnessing a violent crime. So I think that the future is going to be able to provide us a lot of answers along those lines.
And just very, very quickly, I take your point that it maybe has not attributed to the recent decline in life expectancy rates, likely because it has been for a very long time a significant contributor to the rate of death in many of our communities, in particular communities of color. So thank you very much, Mr. Chairman.
Okay, thank you. Senator Murkowski.
Thank you, Mr. Chairman, and thank you for the hearing today and the focus on these disparities. We have some startling statistics in my state. I would say they're alarming. When you look to the mortality rates of American Indians, Alaska Native persons aged 20 to 29 years, it's 10.5 times higher. Alaska Native American Indian persons aged between 30 and 39, 11.6 times higher, and that of those in the 40 to 49, 8.3 times higher compared to their non-Hispanic white counterparts. They're really troubling, and this was before COVID as well. But when you account for these disparities and you notice where we have those that are perhaps most vulnerable, it is for Alaska Native males and those aged 20 to 49. And as I have looked through this report prepared by the National Academy of Sciences, and again, I apologize, I'm only looking at a summary, but I look at the trends in all-cause mortality amongst males and females and the rates. The thing that I find most striking is we have good maps of the lower 48, the continental United States, but we don't have Alaska and Hawaii. And recognizing that our numbers in Alaska are perhaps so disproportionate when we're looking to the disparity, I want to ask, and I don't know whether this goes to you, Dr. Harris, or to you, Dr. Cook, am I just not looking at the full report here? Were Alaska and Hawaii included, and we just have failed to put them on the map? They're on the map of their own because of the awful statistics, but can somebody address that? And then I want to get back to some of the issues that contribute to these disparities.
Now, I can address that first in terms of the report. And I'm so glad that you asked this question, because the data show exactly what you said, that death rates are the highest among Alaska Native and Native Americans. The reason that you don't see them in the summary is because the data quality was not there for us to include with the other groups over the entire period that we examined, which was 1990 to 2017. But the quality of the data are getting better, the reporting of the deaths coming from the various states. And so we do identify several places in the report, how high, very, very high the risks are of mortality for this group and the reasons. And if I could just quickly add, especially in response to what Senator Murphy talked about, I want to really raise the alarm for what's happening to young adults. Yep. As you commented, the young adults 25 to 44 are at very high risk here. And we see this going into the future. They have experienced the greatest increases in drug overdose deaths, as well as suicide, as well as the cardiometabolic deaths. I'll stop there.
Dr. Cook, did you want to comment on that?
No, I
Okay.
agree with Dr. Harris.
Oh, okay. I just want to acknowledge, and again, when we think about health disparities, so many of the other contributing factors that are at play. When we're talking about rural Alaska, in many places is extremely rural. You have over 80% of your communities that are not connected by road. You've got small communities where really in terms of economic opportunity, it is very, very limited. And you've got kind of a clash between a subsistence lifestyle and being able to get everything on your smartphone and find out what is going on in Los Angeles and New York, and feeling like you're being left out of what's happening with the world. And I think we're seeing some indicators, again, as you have suggested, that it is amongst young men who are looking at perhaps their surrounding or their life, and are choosing whether it's drugs, alcohol, suicide, the worst, of course. But also we're seeing that reflected in the high levels of diabetes. Our health outcomes there related so often to what we're seeing as a change in diet, moving from a healthy subsistence lifestyle to one that is contributing to increased diabetes, perhaps cancer, liver disease, kidney disease. So I haven't really framed a question there other than to just share my thanks to the committee for shining a light on this. I'm talking about Alaska Natives today, but we know that American Indians in so many parts of this country today are faced with the same disparities. And it is an issue where we are directing a lot of resources, finally, to the overall health and well-being of Native people. But I think we have so much territory that we have to address that it is going to be a real challenge for us to meet the need. And if we're not all concerned about what we're seeing with young people, particularly our young Native men, we've all got to be working on this together. So thank you, Mr. Chairman.
Thank you, Senator Murkowski. I recall, I may be wrong on this, but in the Pine Ridge Reservation in South Dakota, the life expectancy there is something like it is in Guatemala. I mean, it's really just unbelievably low. I believe Senator Braun is returning, but is that the case? Yeah. All right. If Senator Collins, if you'd like to make your closing statement now, that would be appropriate.
Okay. I want to express my deep appreciation to all of our witnesses today And Chief, I want to encourage you to continue the work that you're doing in York County and indeed throughout Maine and throughout New England to educate people about substance abuse, to help take away the stigma of getting help, and to assist families in recognizing when they have a problem in their own family. I think that is a huge issue. Dr. Cook, I want to thank you for the hard work you're doing each day. I'm going to submit a question for the record to you about the increase in suicides in rural America. In the state of Maine, we've not been immune from that increase, and our most rural counties have the highest suicide rates. That may speak to poverty, to feeling disconnected, to isolation, to higher rates of substance abuse. But I'm going to be very interested in hearing your thoughts on what we can do to get physicians, primary care physicians, to incorporate in an annual physical or any kind of visit a mental well-being check. I think that's really important. And Doctor, I also want to thank you for the research that you've done. It has helped to inform this hearing and helps us ensure, Dr. Harris, that the work that we do going forward is informed by the best possible data that we can get. I think that is absolutely critical. So I'll have some additional questions for the record, but I did want to take this opportunity to thank each of you for the absolutely critical contributions that you're making to help us understand the social determinants of good health and also to assist us in figuring out policies that will help address everything from drug abuse and substance disorders to the increase in suicides that I find so troubling. Thank you.
Well, thank you, Senator Collins, and let me thank our wonderful panelists for their remarks today. As I mentioned earlier, I think our goal is to try to create a society in which our people live long, healthy, happy, and productive lives. Clearly, I think we have got to focus on issues as to why we are behind many other countries, why lower income and working class people now in many cases are seeing a decline in their life expectancy, and what government policy we can bring about to radically change that situation. So thank you very much for the work that all of you are doing and for helping us shed some light on this serious crisis. Thanks to members of the committee who have been here, and with that, I adjourn the meeting.